Hello and welcome. I'm Sherry Russum, your host. And as a reminder, the health information provided during this event is for informational purposes only. And if you have any medical questions, please reach out to your primary care or healthcare professional. Joining me today during this live event will be Dr. Kimberly Costas. She's the Medical Director for Thoracic Surgery at Providence Regional Medical Center here in Everett. And we also have Dr. Luis Albertin, thoracic surgeon, also at Providence Regional. He's also the clinical assistant professor at Washington State University School of Medicine. So welcome to you both.
Thank you. Thanks for having us today.
Glad to have you here. Okay, let's get started. First of all, can you both just please tell us about what you do in your roles with Providence? And Dr. Costas, let's start with you.
Sure. Well, both Dr. Albertin and I are board certified thoracic surgeons. I trained in general surgery at University of Washington and in thoracic surgery at University of Rochester. And I joined Providence and Everett in 2006. I am the medical director for the thoracic surgery program and for the Providence lung cancer screening program. And I was fortunate enough to have Dr. Albertin join me in 2015 to help develop the robotic thoracic surgery program.
Yeah, thank you. I was lucky enough to join Dr. Costas, as she mentioned, 2015. My background, now I trained in general surgery in New York at St. Vincent's Hospital and then at Westchester Medical Center. And then I completed my thoracic fellowship with emphasis in robotic surgery in Long Island Jewish, also in New York. And I joined now in 2015, been here for 5 years now. And the program has been a success since then. In addition to lung surgery, we do robotic surgery for the esophagus, for the thymus, which is a gland in the chest, also for the diaphragm, which is the breathing muscle. And yeah, I'm very happy to be here.
Thank you. Okay, so how common is lung cancer and what are the statistics for survival? Dr. Costas, let's start with you.
Oh, thank you, Sherry. You know, lung cancer is actually the second most common type of cancer, but it's the #1 cancer killer. And the American Cancer Society estimates that there'll be about 228,000 new cases of lung cancer this year and 135,000 deaths from lung cancer. So if you're a man, the chance of you developing a lung cancer in your lifetime is about 1 in 15. For a woman, it's about 1 in 17. Those numbers include smokers and non-smokers. If you're a smoker, the risk is higher than that. So, you know, most lung cancers are due to smoking. 85% of lung cancers are due to cigarette smoking. But there are other causes, such as environmental exposures, radon exposure, secondhand smoke. And sometimes there's correlation between first-degree relatives that have had lung cancer and people who develop lung cancer.
Yeah, as Dr. Costas mentioned, lung cancer kills more than breast cancer, prostate cancer, and colon cancer combined. Now, the overall 5-year survival for lung cancer is about 18%, which is quite low compared to the other ones, which is around 90%, and colorectal surgery about 65%. Now, lung cancer is divided in 4 stages. Usually stage 1, that's when you want to actually catch the cancer because it offers the highest chance of cure. Now, the overall survival is around 60 to 90%. Now, unfortunately, many times lung cancer is diagnosed at later stages, like stage 4, which is more advanced, and the survival for those patients actually is overall poor. Now, if your patients living about 5 years, the percentage is around 0 to 10%.
Oh, yeah. So then it's important to know what some of the common symptoms for lung cancer are so that we can protect ourselves. Can you tell us what they are?
Yes. Unfortunately, most patients with early stage lung cancer, which are the cancers that you want to catch on the beginning of the disease, they have no symptoms. Now, about 2/3 of patients, they present with advanced disease for the same reason. Now, some symptoms that the patients can develop is dry cough. And on rare occasions, patients can have be coughing up blood. Now they can have some unintentional weight loss, chest pain if there's invasion of the cancer into the ribs and the muscles in the chest. But it's interesting because most patients we see actually either they're diagnosed during the lung cancer screening, which Dr. Costa is going to talk more about that, or patients that have a CAT scan for unrelated reason and it's found to have a spot in the lung that end up being lung cancer.
So how can a person lower their risk? Dr. Costas, can you tell us that?
Absolutely. The best thing to do to lower your risk to develop lung cancer is to quit smoking if you're a current smoker. And we have a lot of things that we can do to help you with that. Just keep in mind, it does take 7 to 8 tries to really quit smoking. So don't give up if you failed once or twice or even 5 times. There are a number of nicotine replacement programs available, which include actual nicotine replacement patches, lozenges, etc., or medications that kind of trick your brain into thinking you're getting nicotine. And they can be really successful.
Well, are there certain people that are more at risk than others?
Yes, absolutely. We have, through randomized controlled trials, identified a group of high-risk patients that have these 3 characteristics. Those are patients that are between the ages of 55 and 80, patients who have smoked a pack a day every day for 30 years. We call that a 30-pack year history. And it doesn't have to be exactly like that. It can be an equivalent, like you've smoked 2 packs a day every day for 15 years. And patients who are still smoking or who have quit within the last 15 years. That's the group of patients that are high risk for developing lung cancer.
I know that there's a screening process, a lung cancer screening process here at Providence Everett. Can you tell us more about that?
Yes, actually. So if you are part of the high risk group, you are eligible to undergo a low dose CT scan of the chest for lung cancer screening. And actually, lung cancer screening is covered as a preventative service, and it's covered by CMS. We have a really well-developed lung cancer screening program here at Providence. Patients can be referred to the lung cancer screening program by their primary care provider, or you can self-refer by calling 425-297-LUNG, and LUNG spells out as 5864. When you call into the office, you'll have an intake, and we'll make sure that you meet the high-risk criteria. And after that, we'll set you up to meet with one of our skilled providers for something called a shared decision-making visit. And that's where you'll come in and we'll talk to you about the process and what the risks and the benefits of screening are. And after that, we will set you up to get a low-dose CT scan of the chest. And so this is a CAT scan that only has about 1/8 the radiation of a regular CAT scan. And we do it that way to lower the radiation exposure for patients. And what we're looking for nodules or spots in the lung, because those may be early cancers. So we'll get the scan and we get the results, and we will call you that day or the next day with the results. If there aren't any nodules, then fantastic. We want to keep screening. It's not just a one and done. We have to screen for a minimum of 3 years to really get the benefit of lung cancer screening.
And how successful has the program been?
Yeah, it's been very successful. If we find a nodule or another abnormal finding, then sometimes we'll recommend a biopsy. And our robotic surgery program has really made the identification of these nodules easy. And we'll talk about that a little bit more later. But I want to let you know that, we have enrolled almost 1,000 patients, 986 at the last count. And we have identified 25 patients with lung cancers. And 3/4 of those were early stage lung cancers, and we were able to operate on those for cure. Our cancer detection rate is 2.7%. That may seem low, a low number overall, but actually compared to the National Lung Screening Trial, which was the randomized controlled trial that actually described a benefit for lung cancer screening, their cancer detection rate was 2.1%. And then when we think about it compared to mammography, which is well accepted for screening for breast cancer, that cancer detection rate is only 0.6%. So cancer detection rate for lung cancer screening 5 times that of mammography.
Oh, wow. So if patients wanted to know if they should be screened, where should they go?
Yeah, so there is a really nice, easy website called shouldiscreen.com, and anybody can go there. It's a public website, and you can plug in some information about yourself, your demographics, your pack year, history of smoking, and it will let you know where you stand in the high risk category. So I recommend that website. There are other websites that are helpful too, from the American Lung Association or the American Cancer Society or the Go-To Foundation for Lung Cancer.
Okay, thank you. So, Dr. Alberton, what kind of impact has the Da Vinci robotic surgery technology had on lung cancer treatments?
Yeah, thanks for asking that. That's no, it made a huge impact. So in the past, for lung cancer, we used to make like a large incisions called thoracotomy, and the biggest disadvantage of that is because we had to spread the ribs. Sometimes we even break the ribs in order to try to get our hands inside the patient to perform the operation. Now that has evolved to minimally invasive surgery, and the robot is the latest technology where we can now make just like small little incisions between the ribs. There is no rib spreading, and we can get inside the chest with instruments in a camera and perform the same operation we would have been doing with an open operation. However, without being without having to make a big incision. No, there's less pain because there's no rib spreading. Other advantages is that now we can, now with the robot, we can remove larger tumors without now converting to an open operation. Also, patients that have received the chemotherapy and radiation prior to surgery, those operations can be quite complicated. But because the robot has 3D visualization and it's a much better tool, allows us to perform minimally invasive surgery on those patients as well. Um, since there is no rib spreading, that translates in less pain. Patients require less amount of narcotics, which are stronger pain medication, and they are able to now resume their activities sooner. Um, Usually patients for a standard operation goes home in 1 or 2 days, and and in fact we have a few videos to show to you guys, and which exemplify now one of the benefits of robotic surgery. Now the first one is an introduction to our operating room, and so you can see how the robot works.
Okay, can we run that video?
Welcome to room 312, the dedicated thoracic robotic surgery room here at Providence.
This is the Da Vinci XL, which is made up of 3 parts.
This is the robotic arm portion, and this is where we place the instruments. The instruments are attached to the arm, and they simulate the motion of almost our hands inside of the patient.
And behind us, you have the computer with a screen, and this functions as the brain, which controls the machine. And over the corner is the robotic console, where the surgeon can control the robotic arms and conduct the operation.
What we do to gain access to the chest is we place ports or trocars first. It goes in between the ribs so we can gain access to the chest. So here's an example here. We're placing it in between the ribs. The next step is to place the camera. This camera is a 30-degree camera. We can look up and down with the camera. And so we advance it inside the patient's chest. In this case, it's just a model. One of the amazing things about these instruments is how they mimic our hand motion inside the patient's chest.
If I move my hand up or down, this would move up and down. It open and close just like my hands.
So here we are at the surgeon console. This is where the magic happens. When we sit at the console, the first thing we do is put our fingers into the controls. This allows us to move the robotic instruments. What I'm demonstrating here with this cone model inside our thoracic model is how we can move the instruments in a totally wristed fashion. I can come in, I can get very close, it's magnified and it's 3D. We can move the rubber band from place to place. I can move the camera along with my instruments, and we can safely keep our instruments in the view at all times without risking injury to anything around.
One of the biggest advantages of the robot is for intracorporeal suturing, as you can demonstrate here. Now it's very easy now to do suturing inside the body with these instruments.
Because of the advanced technology of the robot, the wristed motion, the opening and closing, the fine dissection, we're able to do minimally invasive surgery for very complex procedures. That means we can take out the lung for lung cancer. Patients will have smaller incisions and will be home faster. we're really proud of the technology that we have to offer our patients here at Providence.
Well, thank you. I love the tour. How are the robot and the lung cancer screening program related to each other? Dr. Costas, can we start with you?
Absolutely. So, when we're screening patients for lung cancer, we're using the CT scan and we're looking for spots or nodules. That could be early lung cancers. So, not all nodules are cancers. In fact, the majority of them are not cancers. But when we can see nodules in the lung from scar or old infection or from benign growths called hamartomas. But, we need to be able to identify these nodules and access them to obtain tissue for diagnosis. And the robot can help with that.
Okay.
I think Luis, is going to explain a little bit more about that, because sometimes we can't see or feel these nodules.
And I think you're on mute. There we
go. Thank you. Yes. So, one of the disadvantages actually of the robot, as Dr. Costas pointed out, is that you can't put our hands inside to feel the nodules. And now, however, to offset that disadvantage, sometimes if the nodules are too small to be seen or to be felt with the instruments, we have the capacity to look at the CAT scan and use 3D navigation to find the nodule, and we inject a dye very close or at the spot in the lung that we want to remove. And then we can use some special lighting, which we will demonstrate in a short video, in order to access that area and remove the area that is suspicious for having a cancer. Now, here we can see in the video. I also going to point it out that this is normal appearing lungs. Now, this is the color should be. And here's the dye, the area that it has been now injected. So we know exactly, even though we cannot see or feel the nodule, we know exactly where the part of the lung has to be removed. This stapler cuts and seals the lung at the same time. Now we check that the area that is suspicious are being removed. And that cuts and seals the lung. Now we check once again, make sure we have the desired area. And then we place this inside a retrieval bag, and you can remove from the chest cavity.
So does that go just up one of the tubes, one of the arms in the robot? Is that how?
Correct. It's a small incision between the ribs. You're able to place that retrieval bag between the ribs without doing any rib spreading. And now, another advantage is that there is no spillage of any tumor cells or dye outside the chest. It always stays within that bag, which is removed from the chest.
Yeah, I know it comes out and the specimen comes through the ribs and kind of shimmy it out from in between the ribs.
Correct.
Wow, that's fascinating. Okay, so what is the next step after the nodule is found to be the lung cancer? What do we do now?
Yeah, so oftentimes in the situation that we just described, we'll do the wedge resection where we take out the nodule and we send it off to the lab while the patient's sleeping. And we can get something called a frozen section that tells us whether it's a cancer or not. For early stage lung cancers, which means small nodules, no lymph node involvement, the best treatment is an operation to take out the lobe of the lung that has the tumor in it. And the lobe is just a section or an anatomic portion of the lung. So, for the right lung, we've got 3 lobes, upper, middle, and lower. And for the left, there are 2. And so in that situation, we can go ahead and continue with what we call a lobectomy to treat the cancer. And when I'm telling patients what a lobectomy is, I tell them that it's kind of like pruning a tree. So the lung has trunks and branches that go to each part of the lung. So there are 3 trunks. One's called the pulmonary artery that brings blood to the lung. One is the pulmonary vein that takes blood back from the lung to the heart, because the heart and lung are connected. And the last trunk is the airway that fills the lung with air. So when we're doing lobectomy, we find the main trunks, follow them out to the branches that go to the lobe or the area that we want to remove, clean off around them, and tie them off, or actually we staple them off, as you kind of saw in the last video and you'll see in the next video. And we separate that lobe from the rest of the tree. And it goes in a specimen bag and is removed from in between the ribs. We have a video coming up for that, yeah.
Yeah, in addition to what Dr. Costas already mentioned, it's interesting that patients can be quite anxious by the time they come to see the surgeon. And it's important for patients to understand that the whole workup for lung cancer operation prior to surgery can be quite extensive. Sometimes you have to get a PET scan, MRIs, breathing tests, and as important as it is to go and remove the suspected cancer or confirmed cancer, now we want to make sure the operation is safe and that patients can really go home to resume their activities and and they go back to normal life, to their loved ones, but cancer-free. And now we will have a video to demonstrate it, which is called the right upper lobectomy. Also in this video, you'll be able to notice this dark appearance in the lung, which is pretty much tar related to cigarette smoking. It's not cancer, the black is just the tar. Here I'm dividing one of the branches from the pulmonary artery. The upper part is the upper lobe. This is the attaching the lung from the heart. We're looking for the vein. It's called the superior pulmonary vein. And you use the same stapler as I mentioned before, that it cuts and seals the blood vessels. Here's going around the blood vessels, make sure we're free in the space. That stapler divides the vein. And subsequently going to divide the artery, which now has the blood flow just for that segment of the lung that we want to remove. And then you have to divide the upper lobe from the middle lobe. There is a lung parenchyma, that just which is the connection between both parts of the lung. The last part is the breathing pipe. You can see a little bit of air going the bottom part of the lung in there. Once you disconnect the breathing pipe, that part of the lung, this section, the right upper lobe, is completely removed. We then place inside a retrieval bag, just like the other video. And we remove that between the ribs, reinflate the lungs, and place a drainage tube.
Wow. Wow. Well, we have a question from our audience. So what are the side effects of doing this procedure, and when is it not recommended to the patient?
Yeah.
Well,
you go ahead. Yeah.
Yeah, I mean, that's part of that extensive workup that I mentioned. Prior to taking the patient to surgery, we actually want to make sure that the patients are fit to undergo a safe operation. We get what's called a pulmonary function test to make sure that the patients can undergo a removal of either a large section or a small section of the lung without making them disabled. That means we want to cure the cancer, but more important, or as important, we want the patients to live a normal life. I hope that answers the question.
Yeah, no, absolutely. Pulmonary function testing is a test we get where patients blow into a box and it measures the volume of air they can expel and inspire. And there's a number of tests, but we want to make sure that we leave them with an adequate percent of lung function so they won't be disabled, as Dr. Alberton mentioned. In addition to pulmonary function testing, sometimes we have to do cardiac evaluation prior to surgery to make sure that there's excellent cardiac function to tolerate the operation. In terms, when patients are fully worked up prior to surgery and we deem them acceptable for surgery, the side effects are fairly minimal. There will be some loss of lung function. So you may have a little bit more short of breath than prior to surgery. But generally, it's not significant. And we aim to not have patients, for instance, require oxygen after surgery. You should be able to get back to daily activities. And when is it not recommended? Well, if you don't meet the parameters, if you don't have enough lung function, or patients just aren't strong enough to actually recover from the operation.
And I did have a question too, that I would like to go back to something you said, Dr. Costas. So when there is testing going on for the cancer, is that the same surgery as a lumpectomy or is a lobectomy?
So,
I mean, you don't have two surgeries there, do you, or do you?
I'm sorry, can you say that again? We don't what?
We don't have two surgeries there, do we? To have the testing done and then a second surgery to have the lobectomy?
No. So when we see a patient and we're concerned that they have a lung cancer, we'll say, hey, we don't know if you have a lung cancer, but we're concerned and we want to be ready to do the lobectomy if needed. So oftentimes we will have all the testing that Dr. Alberton alluded to, the lung function tests, the PET CT scan, which is a test that looks for cancer outside the chest, and any other things like the cardiac function evaluated before we go to surgery. So we know we're ready to go if it indeed turns out to be cancer when we do the little biopsy in the operating room.
Okay, great. Thank you.
I cleared that up. Yeah.
So what percentage of lung cancer surgeries are done using robotic surgical technology? Dr. Alberton?
That's an interesting question. I mean, depends which database you look at. So now approximately 40% of lobectomies, now according to some databases, are done robotically. And that's a significant, increase. If you compare, for example, in 2010, about 3% of lobectomies were done robotic. In 2015, it was about 15, 17%. But now about 40%, and most of those operations were operations that were done open and now are being done minimally invasive.
Okay. So what are the advantages of having the lung operation with the robot versus the open?
That's a good question. As I mentioned before, I mean, since patients have less pain, they are able to go home sooner. They use less narcotics. It's a faster recovery. They can resume activities, go back to work. And on those occasions where patients have to receive additional treatment, such as chemotherapy or radiation, because they recover faster, they can carry on with any other treatments that it might become necessary in the future sooner.
Yeah, I agree with all of that. I think there's something that was in between open surgery and robotic surgery, and that's called VATS surgery, or video assisted thoracic surgery. And that's where we did surgery with kind of straight instruments in between the ribs. And honestly, the wristed motion of the robot makes surgery, it allows us to do much more complicated dissection. So, we used to be able to take out, less complicated portions of the lung, but the robotic surgery allows us to do complicated procedures, larger tumors that are closer to the heart. We can take out tumors where patients have had chemotherapy and radiation before, whereas that was very difficult with VATS. So there are a lot of advantages. We've already talked about length of stay. The length of stay, meaning how long you're in the hospital after surgery, with the open incision or the thoracotomy, historically was 5 to 7 days. And that improved when we went to VATS surgery to about 4 days. And our length of stay, our median length of stay for robotic lobectomy now is 2 days. And that's just amazing, cutting 5 days off a hospital stay with the same or better outcomes. So
yeah, that's great. That's great. So who could someone talk to if they wanted more information regarding lung cancer surgery and treatment options?
So we're always available. I should be able to put on the screen, but there is a number for our office. If you just, either look it up on the internet, you can call this number that's showing the screen. Myself and Dr. Costas, we're always available to answer any questions, to patients, to referrals, referring physicians, I would say. And that's as easy as a phone call.
Yep, no problem.
Okay, and is there anything else before we close out our session here? Is there anything else that you'd like the audience to know about lung cancer awareness before we close?
Well, thanks for the opportunity to talk with you all. If you're a smoker, we understand. Try to quit. We're happy to help you with that. If you reach the high risk criteria, please go to your lung cancer screening program. It's definitely beneficial.
And I believe there is one more question that's in the box in there.
Oh,
I just saw that pop up. How do you decide between open or robotic surgery?
So that's an interesting question as well. I mean, we try to push the envelope, and that's why over the last few years, 95% of the operations we have done have been robotic, unless there is clear invasion of the blood vessels, or that we really deem that it's not safe to use the robot. We always try to do a minimally invasive operation. Obviously, for now, some more difficult operations, we know that there is a possibility we might have to convert it to open. In fact, we are always prepared to do an open operation. I like to tell patients this is a cancer operation, not a cosmetic surgery. If I can do the same, exactly same cancer operation with the robot as I would have done for an open operation, great. It's better for the patients, easier for me. But we never put the oncologic aspect of the operation in jeopardy just to use the robot. So now we try to do, now always do minimally invasive surgery with the robot when feasible. However, if necessary to do an open operation, which we do sometimes, that's when we do it. I don't know if Dr. Costas would add anything to that.
No, I agree. Invasive whenever possible. I think the things that may make us convert to open would be a very large tumor at the base of the lung, or a tumor that may be heading toward the heart, like on the main vessels coming out of the heart. Those are things that are hard to do robotically. But we have done complicated surgeries, like Dr. Alberton has removed the entire lung robotically. That's called a pneumonectomy. So those are things that we were not doing with the VATS procedure before robot.
Okay, great.
And there's one more question.
Okay. Is this procedure available for stage 3 that has impacted lymph nodes?
Yes, it is. And so that's what we're talking about. For patients who have stage 3 lung cancer, our approach actually is induction chemoradiation, which means before surgery, chemotherapy and radiation, and then restaging to make sure there hasn't been progression. And if not, then yes, we can often do lung resection and clean out the lymph node basin robotically.
Okay.
Yeah, I would add that removing the lymph nodes is as important as removing the cancer. Even though we don't have a video to demonstrate that, is a standard part of the operation. Now, it's remove the cancer and remove all the lymph nodes that could potentially be involved by cancer.
Okay. I don't see any other questions. So with that, I want to thank you both. Unless you have something else that you feel is really important to say about lung cancer awareness or any of the topics.
No, I think we're running out of time, but we are happy to see you or talk to you or answer any questions you may have. Give us a call at the number we listed before.
Okay, well, thank you, Dr. Costas and Dr. Alberton, for joining us today. And to everyone for listening and sending in your questions, we really appreciate it. To learn more about our initiatives, programs, services, ways to give, or if you're looking for help or medical advice, please visit providence.org. And make sure to follow us on social media at Providence on Twitter and at Providence Health System on LinkedIn, Facebook, and Instagram. Thank you, everybody, for joining us.
Thank you.
Thank you.
Bye-bye.